Hello, hello, and welcome. Just gonna let you all come in. Just take a moment so that nobody misses anything. Not that there's that much we start with. So hi, my name is Susan Weinstein. I am co-executive director at Families for Depression Awareness, and welcome to our webinar, Mental Health Crisis Planning, How to Develop a Proactive Strategy. I am really glad that you could join us. And I happen to be an attorney. I don't always disclose that, but with that point of view, I am thrilled that we're able to bring you this information to put you in the driver's seat as you navigate the mental health system. And we really want to give caregivers the legal authority that they need to advocate for their loved ones. Momentarily, we'll launch a poll so we can get an idea of your familiarity with the topic. And it's on my screen. I hope it's on yours too. We expect that this webinar will last about 90 minutes. We've reserved time toward the end of the program for questions and answers. We do have the questions that you submitted with your registrations. Many of them we were already planning to answer during the program, but we also invite you to type your questions using the Q&A feature at the bottom of your screen. We will hold the questions to the end, but submit them as we go throughout the program, and we will get to as many as we can. We also have the chat open. It gives us a chance to provide you with some helpful links and to give you some information, but it's also a chance for you to communicate with us and with each other. We do ask that you be respectful and that you really please don't share any private information publicly. At the end, we will ask you to complete a brief survey. Your input helps us improve our programs and deliver content that's meaningful to you and to other caregivers. We appreciate you taking the time to share your thoughts. We also will be giving a modest Amazon gift certificate to one lucky survey taker. So please, please do. As you will already know from having logged in, we're recording this session. So if you need to leave, don't worry about it. You'll receive an email around this time tomorrow that has the link that you can use to watch all or some, and also gives you a chance to share it with others. For this and for our previous webinars, check out our video library at familyaware.org/trainings, and also on our YouTube channel, which is FFDA1, the number 1. Also, I'm really excited about this. For a deeper dive into this topic, please join us at 7:00 p.m. Eastern Time on Thursday, April 4th, on Facebook at Family Aware, or on YouTube at FFDA1. We will be doing a live stream and hearing personal perspectives and unpacking the power of psychiatric advance directives. Okie dokie. Now, let me just say a few things about Families for Depression Awareness. We're a national nonprofit organization that educates and equips family caregivers to provide effective support to their loved ones who live with depression or bipolar disorder, while also taking care of themselves. We know that one person's mental health impacts others in the family, whether it is a genetic predisposition to depression or bipolar disorder, managing logistical issues in the household, or even its effect on interpersonal relationships. We want every family member's mental health needs to be recognized and addressed. Whoops, a little too twitchy there. You've probably already been to our website because you registered, but you may not have had the opportunity to explore the depth of resources that we offer. Sharing the stories of people with lived experience has always been central to our organization's approach. We're grateful to our volunteers who open up about their challenges and successes to inspire and instruct other caregivers and help them to feel less alone. We strive to provide clear information and actionable advice to caregivers, and we create tools like our Family Action Plan and our Caregivers Toolkit to help caregivers move forward. This is the agenda for today. We are going to have an overview of mental health crisis planning. We will review the elements of a Psychiatric Advance Directive, which we will refer to as a PAD some of the time, but probably most of the time. We'll discuss the role of caregivers and family supporters in this process. Then we'll go, as I said, to the questions and answers, and we will then direct you to our survey. I believe we have the answers to our webinar poll. Almost everybody participated, so thank you. How much do you know about mental health crisis planning? It says we have about half who say some. We have about 10% who say a lot, and about the same number of people, 23%, said a good amount or not much. So yay, you guys aren't experts, but hopefully you'll be close to that when you are finished with this program. Stop sharing. Okay. Now I will take a moment to introduce our fabulous featured presenters. This webinar, just so you know, has been created through our collaboration with the Copeland Center for Wellness and Recovery. We're pleased to welcome these speakers. And I'm giving a shortened version of their bios, but if you want to see their complete bios, just go to familyaware.org/trainings and click on this program. All right, here we go. Amy Detmer has been the program manager of the SAMHSA-funded Doors to Wellbeing National Technical Assistance Center for Mental Health Recovery at the Copeland Center. Amy has lived experience in youth serving systems as she was institutionalized in a youth residential treatment and diagnostic center as a teenager. Turning her experiences into meaning, she graduated from peer specialist certification training in Pennsylvania when she was 21 years old. Since certification, Amy has worked as a certified peer support specialist in community-based settings, residential settings, and as a peer support supervisor. In 2016, she started working with the Copeland Center, providing peer support and wellness recovery education nationally. Amy's work focuses on peer specialists, youth leadership development, peer-led recovery education, and psychiatric advance directives. Welcome, Amy. Thanks for being here. Matthew Federici is the Chief Executive Officer of the Copeland Center. Before coming to the Copeland Center in 2010, he served as Program Director at the Institute for Recovery and Community Integration, creating systems transformation through the implementation of certified peer specialist training program across Pennsylvania. Matthew is an internationally recognized speaker, trainer, and consultant on recovery, wellness, community inclusion, and peer support. Matthew's personal and professional journey in wellness and recovery includes involvement as a family member and a mental health consumer advocate for over 20 years. He's been involved in promoting psychiatric advance directives through local, state, and national consumer and provider conferences, and is a certified psychiatric rehabilitation practitioner. Thank you for being here, Matthew. And certainly not least, as the CPRS training coordinator at On Our Own of Maryland, Kaylee Whittington coordinates multiple grant-funded projects, provides technical assistance for certified peer recovery specialist-focused initiatives, and presents training based on identified needs and emerging trends. Previously, Kaylee served as a family peer support specialist for the Eastern Shore Mobile Crisis Team. She has spoken about her lived experience through a national panel with SAMHSA and the Mental Health Association of Maryland's Youth Voice Video Project. Kaylee is passionate about using her lived mental health experience to advocate for others, empower her peers, and promote autonomy. Welcome, Kaylee. Thank you all for being here. This is awesome. We're really excited. And I believe at this point, I will turn it over to Amy.
Thanks so much, Susan, for making this webinar possible for us today. I just wanted to briefly maybe go into a little bit further introduction for Matthew, Kaylee, and I, and then I think Matthew's going to touch on who the Copeland Center is and why we're collaborating with Families for Depression Awareness. So I just wanted to continue to say that some of my work with psychiatric advance directives and crisis planning but primarily in the Psychiatric Advance Directive area has taken me into being involved in national councils that focused on PADS. I've been involved with peer-supported PAD education. And it's really been something that I'm very excited to be here today. I've used crisis planning many times in my own life, and I have a Psychiatric Advance Directive to kind of continue guiding my own process. So I show up today with my own lived experience, and I'm excited to share with you all. So Kaylee, did you have anything further that you wanted to introduce about yourself?
Of course, thank you, Amy. My name is Kaylee. I am very passionate about psychiatric advance directives. For me, this has been something that's been so empowering and that I feel has given me a way to have a voice and to have a say in a situation that really felt very out of control. And in speaking with my mother, one of my strongest supporters and advocates, she has echoed the same. I work for On Our Own of Maryland, as previously mentioned. For our disclaimer, the views, the statements, and contents expressed on this may not necessarily represent the views, opinions, or policies of our board of directors or the funders of On Our Own of Maryland. And Matthew, did you want to go?
Just going to unmute here. Thank you and welcome everybody. Thank you for making time out of your schedule to attend this. And I do also really want to express some gratitude here to Families for Depression Alliance. And just wanted to say, you know, I'm currently the CEO of the Copeland Center for Wellness and Recovery. And we also operate a program there. It's called Doors to Wellbeing. And Doors to Wellbeing is a national consumer peer technical assistance center, and we receive part of our funding from SAMHSA. And you know, similar to what Kaylee shared, you know, this presentation doesn't represent the views or policies of the funders. Where a lot of this really comes from is, for me, is a very personal place and space. So as somebody who you know, has the lived experience of being through the psychiatric hospitalization situation. And I was very fortunate to have family members that really came from the values that are represented in our organization, as well as the Families for Depression Awareness. And we're really great partners because we share very similar values about choice and self-determination and empowerment. Even when things are difficult. And I've had the great privilege of having family members that really maintained those values at a time when psychiatric advance directives weren't even talked about and recovery wasn't even known. But not only myself, my older brother went through not only incarceration, but also state hospitalization. And so I really come from that lens of a family member on multiple levels, as a person who's gone through their own journey, and then as somebody who went to work professionally in many different settings, group homes, employment programs, partial hospital settings, and really seeing the lack of equity. Like, I had a family that really was able to support me to not lose my autonomy. I made some really bad decisions when I wasn't well, but no one ever took away my dignity of not making decisions. I was always engaged to the fullest extent I could and really supported. And in many ways, I had a psychiatric advance directive in place. I want to share with you, I have two lovely children, both teenagers. You know, I have a comprehensive advance directive. Living Will includes my decisions about mental health and overall health care. And I just feel really well prepared for things in life because of all those lived experiences. And I really want to support as many people as possible to take seriously the opportunities we have for empowering people to maintain as much dignity and choice in their lives. I have older parents now, older in-laws, and the use of psychiatric medications in nursing homes and older adult such situations is just another warning that we should all really think about if we find ourselves in a situation where people are considering to provide any kind of healthcare, we need to get our wishes and choices down sooner than later. So I'm really passionate about this. Again, I'm really grateful to On Our Own in Maryland, Families for Depression Awareness, and Kaylee and Amy's specific support, and Susan's gracious support as we got ready for this webinar today. So really excited to jump into this.
And also, could we go back to the next slide real quick? Or the previous? Yes. I wanted to touch on Our Own of Maryland. So what our organization, or On Our Own, is about. On Our Own is a nonprofit, statewide, peer-operated organization that really focuses on advocacy in the behavioral health system. A couple of ways that we do that is providing technical assistance. We have an affiliated network of wellness and recovery organizations. And in my role, I have a lot of focus on training and really just trying to help folks entering the peer support specialist role get to where they need to be to become certified and to really make the best out of such a rewarding opportunity.
All right. Well, with that, you've got to hear a little bit about us and our organizations. Now we want to open the space to hear a little bit of who you are and the community that we're a part of here together. We have about an hour and 15 minutes left in this space, and we're going to try to make it as interactive as possible. We have some polls, we have some engagement questions like this, and just some other things in store. And then, of course, the Q&A at the end. But this is really the first space that we have for the interactiveness, and we just invite anybody who wants to chime in the chat by sharing your name, what you hope to get from today, and a little bit about the community you're from. And I can model this with my name, again, is Amy Detmer. What I hope to get from today is just a continued, I guess, connection around the shared passion. I already know Matthew and I already know Kaylee. We've worked together on other occasions. And whenever we get to talk about this topic together, and I'm sure you're going to see it, we kind of light up the room with passion. So I'm excited for that shared connection this evening. And a little bit about the community I am from. I'm joining from a place, a very special place to me. They call it the Northeast Kingdom, and it's in northern Vermont. And that's where I'm joining in. And if you're here and you want to, like I said, just feel free to throw it in the chat, your name, what you hope to get from today, and the community you are joining from. And while we're waiting for some other comments to come in the chat, feel free, Kaylee or Matthew, to jump in with your own example of this as well.
Sounds great. Thank you, Amy. My name is Kaylee. The community that I am from is the Eastern Shore of Maryland, as well as the peer community. And what I'm hoping to get from this webinar is definitely deepening that connection, but also I'm really looking forward to hearing from some of the families, the caregivers, and supporters, and just being able to see that passion for advocacy and that love, because being on this webinar and taking these steps to become educated so that you can be the best advocate for your loved one is something that I think is amazing and really warms my heart.
Thanks so much for sharing that, Kaylee. Happy to hear your passion in the advocacy. We do have a couple other comments coming in the chat. We got Brinny saying, my name is Brinny. I'm a peer supporter in Western Mass. I hope to learn about how to utilize the principles of a PAD in Massachusetts, where PADs aren't recognized as a legal document. So we'll talk about that. We have experience nationally and the differences of PADs. But thanks for joining, Brinny, for some more insight. We have Maria saying, Maria is looking for tools to help support my 20-year-old son, who's a college freshman, recently diagnosed with bipolar, also from Massachusetts and working for the school system. Thanks, Maria. And I'll read just a couple more here, and then we'll invite you to kind of read the others that are coming in as well. We have Reagan joining from, I lost it. Saying that they hope to learn more about mental health crisis planning and a certified peer recovery specialist from Strength in Peers in Virginia. And I'll read one more. We have Michael saying, Michael with mydirectives.com. Hope to learn more about what is happening in Maryland with mental health directives, and I'm in Frisco, Texas. I'm seeing some other people from Michigan, Boston, lots of comments coming in. Really cool to see people from all over the country: Ohio, New York, Nevada, Hawaii. Awesome to see such a diverse representation of people here with us today. And with that, I think I'm going to lead it into our next slide, which Kaylee's taking it over for a poll.
Thank you, Amy. So we are going to launch a poll, and the question for this is, if I were ever deemed incapable of making financial or health decisions, including mental health decisions, would I want a trusted person involved to ensure my wishes are followed? So we've got a poll running, and I encourage everyone to drop those answers. And let's see, I'm seeing my poll part disappeared. Oh no. Awesome, thank you. It's popped back up on my screen. The technical difficulties have been resolved. So I'm seeing quite a few answers coming in, and we'll give a few more moments to let the rest of the folks put in their answers if they would like. So far, I am seeing a lot of yes. So where we're standing right now, we've got about 94% yes and 6% I am not sure. What I'm also seeing in here is there are no no's. So what I'm seeing in this poll is this is something that advocacy tool is in high demand. And this is something that a lot of folks are very interested in. So thank you for completing that poll. And yeah, let's move on to the next part.
And as I move into this next slide, I'll just say I really appreciate you taking the time to answer that poll. I think it really helps us kind of set the stage, or at least understand who we're sharing this space with, and really kind of this vision. 94% of us said yes, we'd absolutely want that. So this is something that all people, most people would really want in their lives as we go about that. So think about that as we go. But a couple things that we are going to cover today are learning objectives, which are to recognize the benefits of creating a mental health crisis plan. We're also going to take some time to explain what a Psychiatric Advance Directive is and what one may include. And we're going to determine the role of family members in supporting a loved one through crisis planning. I do also want to articulate that this event is not intended to provide legal or medical advice. You may hear some of our own personal sharing around things. We may talk about Psychiatric Advance Directives being legal documents, but we're not giving any legal or medical advice throughout it. Going into our next slide on our mental health and well-being crisis plan, it's really important to recognize a couple things. First, that we can take action on our own behalf to educate ourselves and create plans to minimize distress. I will say that for my own self in my recovery, in my wellness journey, it was really this right here that I realized, like, oh my goodness, I can do something to support myself and educate myself. And it did de-stress my life. I'm really living proof of that statement. And I've met many, many other people that can speak to that as well. When we're talking about well-being crisis plans and psychiatric advance directives, it's important to remember that we can do this to increase positive outcomes for ourselves and our supporters when things feel out of control or overwhelming. I used to really go in the mindset of crisis planning was for me. Psychiatric advance directives were for me. Today, I don't think that. Today, I look at it like, oh, well, me completing this is for me, but it's also supportive, almost like a gift to my supporters. So it's something that we can do and can create positive outcomes in many different ways. It's also really important to recognize that as humans, we have the human right to direct our lives and how we are cared for. So this really gives us a platform for that communication. What do we want in our lives? What do we not want? And we have a right to be able to say those things. We deserve dignity of choice, being able to make our own decisions about what we want, even if those choices don't make sense to other people. We deserve to have self-determination. and to learn and grow. And all of these things that we talk about, times of crisis, I know I can look back and say how many times I've learned from the situations that I've been in. And that's really the mindset we try to frame in, that it's not something to stigmatize or shame people for going through crisis, but that it's an opportunity for strength and growth and learning to happen. There's no evidence that having a disability, whether that's mental health or otherwise, that means that we do not, should not, or cannot make any decisions about our medical treatment in life. We really come into this with the perspective that we believe all people can make decisions about their lives, even if others don't think that they should be. And that whatever diagnosis or disability we have, we still should be having say in our lives. And again, this is an opportunity for us too. I do want to also mention kind of this bottom piece on the slide, that there may be times when we need advanced plans with our chosen supporters in place, and we'll talk about that as we go. So what about a mental health well-being crisis plan? Crises in general, sometimes these can be episodic, meaning, you know, one time here, one time there kind of thing. Sometimes it can be very brief, very short-lived situation, or prolonged over a number of months or even years. People can kind of live in this kind of time of crisis. A crisis may include medical issues and also may not. During a crisis, we must increase support from others, whether that's loved ones and natural supports around us or medical supports. It's a time where we need to increase that in our lives. We have the capacity to recognize what is working and what is not working, what we dislike, and what might support us the next time. So again, this fits in that theme of learning and growing, having the dignity to make choices and recognize and say, I like this, I don't like this. We all have the right to advocate for how we want to be supported and not supported during these times. And we're going to keep giving you examples of that as we go today. Going into the next slide here, this is talking a little bit more about well-being crisis plans, and thinking about how a personalized well-being crisis plan can be developed and used by anyone to avoid or reduce the distress of any type of crisis in our life. It can be shared with any supporters we choose. And this is kind of some general guidance for what I like to consider kind of the key components of what goes into a crisis plan for me. But this can be shorter. It could be some pieces of this. You can even expand it further if you want to. But here's some categories that really fit well for me and the type of well-being crisis plans that I have. Looking at things like, what am I like when I'm well? Kind of giving myself a opportunity to be like, oh yeah, I'm really not at that place of wellness right now. Being able to differentiate wellness from unwellness in my life. Also, what are the signs or indicators that I need assistance from others? So at what point do supporters know that maybe they need to step in because I am not doing well? Maybe that's having suicidal thoughts. Maybe that's getting into physical altercations with other people. What are those signs that supporters can see that I may be entering that time of crisis? Then there's questions like who can support and who not to be involved. So, you know, there's supporters in my life, my mom, who I want involved, and other supporters like my father that I'm not really interested in having him making any decisions. So again, we can say who we want involved, who we don't. We might want to have an information sheet that includes information on health providers and resources, and the things that support that. Sometimes having things like, where can my insurance information be found? Any type of like medications or doctors, certain doctors that I see. I like to have a pretty robust list to kind of help that clear communication happen from one supporter to the other. A well-being crisis plan can also include things like treatments and complementary therapies. So, you know, I would like things like Reiki. I also want to be connected to peer support as much as possible. You can kind of list out again what works, what doesn't work. And one of my other favorite sections of well-being crisis planning is respites, home and community supports. And this is like what's available in my community to me. I know where I am in Vermont, it's a little far from me, but it's available to Vermonters. There's what they call a peer-run respite center, which is a bit of an alternative to a hospitalization, where I could go and be surrounded by peer supporters for a short stay, less than a week, and just kind of regroup, reflect, be able to kind of work through some of the situations or stressors of my life so that I can go back into my life after I've worked through some of that. I'd really encourage you to kind of look into your own community and see, are there things that you know already work, or that you might want to try. Then the next thing on this circle that I'm going through is hospital or treatment facilities. So are there um, certain preferences that you have for hospitals that you'd like, or hospitals that you'd want to avoid? One thing I've commonly heard from other people is kind of this idea of, can I go to a hospital that has free parking, because then I know that my supporters will be able to come visit me more, and I'll have the support that I need in my natural life as well. Whereas paid parking at hospitals can sometimes create a bit of a equity issue, where not everybody can go, and not everybody can go support our loved ones the way that we might want to. Another thing, and we're going to get into this piece as we go through the webinar today, but ideas about what helps and what hurts, that can all be part of our crisis plan. What's good for us, what's not. And then the kind of final piece that we always like to include is, what are the indicators of recovery from crisis? So how will people know that I'm no longer in crisis? For me, this looks like when I'm making that list of like, what did I learn already? What do I need to change in my life moving forward? So that's a bit of crisis planning. I do want to invite Kaylee or Matthew if you have anything to add to this before we get into the next slide.
Yes, thank you, Amy. I would love to add, because I have my own well-being plan, which is a little bit different than my Psychiatric Advance Directive. When I'm looking at supports on mine, there are certain people who are really amazing friends and really great supporters for me. However, I might not necessarily want them involved with mental health aspects of my life. Or on the flip side, certain family members who are fantastic with the mental health portion, but maybe there's aspects of my personal life where I'd more want to lean on my friends for that support. Also, other things like hospitals and treatment facilities. For me, I found partial hospitalization to be very helpful. So that's part of my well-being plan, that if things are getting a little bit more unmanageable for me, I would prefer to be in a setting where I'm able to go home at night, but I'm still able to get the level of treatment that I feel I need.
Thanks, Kaylee. And Amy, thank you for that. I think what I'd have to say about that is going to just take us into the next slide. I want to share that I'm coming from a really holistic perspective as somebody who's both been in both hospitals for physical issues, but also mental health, and really went through a journey. When you go through a journey of any type of health crisis, you go through it as a whole family. So my brother is a certified peer specialist now, has been for like 20, 30 years. The years just keep adding up. I've been working in the mental health with various different hats. So I really take this proactive strategy approach to seeing that, this isn't just about, having a mental health diagnosis, right? This is really about the importance of mental health overall in our life. And so I want to share that my perspective is that this topic isn't just for someone who's currently maybe going through some difficulties with mental health, but it really is for all of us. And so what Ari put in the chat box, and maybe we could just throw it in there again too, is a document called Action Planning for Prevention and Recovery. And you can get access to that. That has all those components and more that we're pretty much going through. And for about 20 years now, my focus has really been on through the Copeland Center, certifying and training people on how to engage in a group process us to, I saw somebody said, these are really great questions. I've never asked, never thought about these questions before. And they are really great questions, right? As someone who has been in a provider role, a family role, and a personal role, they are spot on questions that we all need to ask ourselves and that we can learn from each other's experience around those questions. Like, what am I like when I'm well? And I'm going to go over what's up here on this slide too. But what I want to share is that this action plan for prevention and recovery, which is also part of the Copeland Center's Taking Action for Whole Health and Wellbeing training curriculum, that all these questions you're hearing and seeing today, they were all developed from people with lived experience like me, but also with the input of family members like me, and also care providers like me. So this has been developed for many years with inputs from lots of people, and it was also research that when we engage in a particular, we're going to talk a little bit later about the values and practices and how we engage each other with these topics. But it has been known to reduce hospitalizations, reduce interference of symptoms in our lives, and it has well-established evidence base that when we engage in these ways, right? But as you can see, there's a lot of components here, and all these components are really going to be a complement and a support to when you are ready to sit down and make a legal document, which is what we're talking about. And so we can increase our self-management of potential crisis through a process of proactive action planning. And this taking action is evidence-based. And so here are some overarching places that are really good places for all of us to start with, right? Developing a wellness toolbox. What you see here, wellness tools. And I would just encourage you to throw in the chat and share with each other, because that's what this is all about. What are some of those simple things in your life that are your wellness tools? They're safe, they're non-invasive, you can use them anytime. And like I said, when someone in our family is going through a crisis, we are all going through a crisis. I did a panel once with my mother, my father, my brother, and myself. It was in New York, and it was a family mental health conference. And we all got up there, and for the first time, I actually heard a little bit more about my parents' experience. And I heard my dad actually say, I didn't eat or sleep for 3 days. I lost 20 pounds. And for the first time, I heard him say that when my son was hospitalized, I went through depression, right? Did he need medications? Was he in a crisis? No. You know why? Because he had my mother, and they worked together, and they had that peer support. And then, yes, they also really benefited from not feeling totally alone, because they went to other family peer support groups, right? And that's what this is all about. Thank you for participating, coming. I see the decorating my house, Legos, exercise at my friends. I mean, these are those little things that make a big difference when we're having a really bad day. We're overwhelmed. We don't know what's going to happen with our loved one, right? We can go into crisis too, or we can just have those early signs like my father was sharing, right? There were early signs, but thankfully we were all in the mental health arena now. So, they were getting the support they needed, right? The other part of this is thinking about creating a daily maintenance plan. And there's 3 parts to this. The daily maintenance plan is, first, you saw this earlier when Amy was talking about a crisis plan, and that is, what am I like when I'm well, right? And that's important. That's going to be important in our advance directive, because we might be in a setting where people don't really know us. They're just looking at us medically. And like for myself, I'm very talkative, right? And but when I was not well, I was very contemplative and quiet and didn't talk very much. And if one day I woke up and I was well and I started talking a lot, well, guess what? There are the situations where now I went from being depressed to being manic depressed, right? Back then, right? And so I'm not owning those labels. I'm saying that when people don't really understand where we're coming from, then we can fall into these perceptions, right? And so being able, first for myself, to know what I'm like when I'm well, because that becomes my action planning process. Like, I can now think about, what do I need to do every day to support that vision of being well? And then what are those things I need to do on occasion? And again, when our family's in crisis, we're all in crisis. And to a certain degree, we're all experiencing big feelings. And so having this, even as a family member, to think about, that it's like that oxygen mask idea, right? Is, all right, getting together with your partner, if you're both supporting a loved one who's going through a difficult time, and thinking about what are our wellness tools? What do we like when we're well? And how do we support ourselves to be there? And what are things that we need to do? Like, even though we're going through this, we still maybe need to, as a family, get away and take a short trip. And that's where we might need to enact supporters, because maybe our loved one is really going through some ups and downs, and we feel like we can't get a break. That's like a crisis. We need to have people who can step in. The next part of this is action plans for difficult times. Like, what are the triggers and our action plans for those triggers? What are our early warning signs and the action plans for those early warning signs? And what are signs that things are getting worse, right? Again, I'll go back to my father sharing what he may have described as early warning signs are when things are breaking down, that he wasn't eating or sleeping for 3 days. And so I can't press enough that one of the ways we can support our family members is to pick up this evidence-based practice and think about what we can do for ourselves to be well, and then share that. So the goal is not just to react better to the crisis situation in our life, but to reduce the frequency and impact of crisis in our life and have greater periods of well-being. This is not this will solve all the problems that we're facing, but it can help us through those challenges. Our Psychiatric Advance Directives are enhanced by this holistic life process of self-reflection and direction. And again, this is an evidence-based approach, and it's been developed through the Action Plan for Prevention and Recovery, the document that was provided to you. So you can begin to take a look at that, get started, make that a part of your wellness conversations that you have, and really think about how we can support ourselves in that capacity. And this is where is the best place to start. I mean, just jumping right into, let's do an advanced directive, let's do this legal document we'll give to your medical provider. And then you start opening it up and start thinking about the choices you want to put in there. That's a hard place to start. But when you can begin with these pieces, they can support us. Like, when we think about what our early warning signs and action plans are, that can support us to then begin to think about what treatments we want or not want, and start to inform those who are taking care of us at a time where things are really intense. They can know how to support us better. Really developing this and a crisis plan will allow for our loved ones to advocate for us when in those intense moments. I think we've all gotten to a place in our lives where we have experienced intensity and we're not in the best place to be making decisions. Boy, wouldn't it be great if the people around us kind of knew what to do then.
I just want to jump in real quick and say, sorry, Kaylee, how much, Matthew, I appreciate you opening this as like, this is a starting point. And just speaking from my own experience, this is really the types of proactive strategies that I've stuck with and built and have used to maintain wellness and recovery and well-being in my life. But I was in wellness tools and daily maintenance planning, and then this action planning for difficult times areas for a good 2 years before I could even open up the box of looking at crisis planning and what that was going to look like. And then it was another few years until I could completely open up the box and say, what is a Psychiatric Advance Directive legal document going to look like? So I say this with just also this, like, it was so supportive to have people in my life that like gave me that space to work on this in my pace, not at the pace they wanted me to work at this in. Some of this stuff is hard to look at. Raising awareness of the struggles that we face can be very challenging at times, and it takes a lot of work. So I just really appreciate how you opened it up with that. This is a starting point as we kind of move into Psychiatric Advance Directives from here.
Matthew, I also wanted to add, I can really relate to what you are speaking on with your father and hearing his perspective as a loved one supporting someone having a crisis or their own experience. I had a similar situation when I did an interview very recently with Families for Depression Awareness, and sitting next to my mom and hearing from her side how she experienced the crisis, and from her perspective was very eye-opening of the impact it has on families. So I definitely want to echo what you're saying with it's not just one person in crisis, it's everybody going through and experiencing a hardship of that of the crisis. So thank you for sharing.
Thank you, Amy. Thank you, Kaylee. So, again, something for us to all think about, and we can each utilize these elements for ourselves. And I also believe that we can all. I mean, I'm at a place in my life now where I have a comprehensive legal document that includes who's taking care of my kids, what happens with finances, but also if I find myself in a situation where psychiatric treatment is involved, what my choices are, who I want involved, and I have different people involved for different things. Some of that may be supported or not supported by the law. It doesn't matter. I know the impact it had when I was in the hospital, that I had active family members coming in with notebooks, writing people's names down and, speaking on my behalf. So if they've got further a written out document where a lawyer and I signed it, doesn't matter what the law says. There's things in writing, there's advocates and witnesses, and it's going to carry a lot of weight. And I can't emphasize enough, taking advocacy seriously. We have some fundamental rights here. So let me just talk about, I think once we create that foundation and we begin those conversations that we just kind of went through, then it can really support us to think about an advance directive which outlines a person's wishes. And bottom line, our wishes in the event that we are incapacitated or unable to express wishes for healthcare treatments. And we can all find ourselves in that situation, right? So it's important to note that, again, regardless of the fact that there are various different state laws, and I see Ari put it in there, the National Resource Center and Psychiatric Advance Directives, which can help you sort out where you're at and kind of some of the guidelines there. But either way, if you are in a facility receiving Medicaid or Medicare under federal law, and they're getting paid reimbursements through them, they're required to use advance directives. Individuals with physical and mental health conditions are covered under this mandate. So again, the federal law and those programs understand that it doesn't matter what type of health treatment you're getting, mental health or physical, that you have a right to an advance directive, meaning you have had a right to put your wishes and state your wishes, and you have patient bills of rights, for example. So, if you're saying things, which we're going to get into, like ways to make statements that are more legally enforceable, this is something we should all really seriously think about. Some of us may find ourselves in a situation in our older adult years in a Medicaid or Medicare facility, and I'll tell you, psychiatric treatment is a part of all those programs, whether you've gotten a diagnosis specifically of quote unquote mental illness. A psychiatric advance directive, which some states have laws around, is a legal document that is specifically allowing people to make decisions and preferences regarding mental health treatment. So in the event that you are, for mental health reasons, determined to not be able to make decisions about treatment, or determined to be incapacitated, which is defined differently in different states, right? In effect, the person is giving or withholding consent to treatment in advance of when this situation occurs, specifically around that. So I know in my state in Pennsylvania, much to my chagrin, instead of really just expanding the current advance directive laws in Pennsylvania so that it enforced more decision-making around medical decisions, they created a very good psychiatric advance directive law, but it kind of left our general health care law a little bit more vague than I would have liked. So in different states, there's going to be different weight given, but I can't emphasize enough that regardless of what the specifics are in the law, we can all benefit by empowering advocates and supporters in our lives to be informed about these important decisions and be prepared to come and be involved in our medical care and say, no, this is what Matthew wanted. He said that he wanted this for this reason. And again, regardless of any kind of legal situation, if it's documented and a family member is coming to the hospital and saying, if you give this to Matthew, he will have an allergic reaction. They're a lot more accountable than if they didn't have that information and then I have allergic reaction, right? And that's kind of just to illustrate the seriousness of really having people involved in our lives that know what our wishes are and have that information.
So the next part that we are going to get into is, what is a psychiatric advance directive? So these are ways to prepare prior to a crisis in advance. Hospitals are not fun places, and I think I can speak for a majority of folks that we do not want to be in hospitals. I think being in a hospital, that situation can become a lot more intense if you are in there by yourself and you don't have folks to help support you, or you don't have the ability to make decisions for yourself. So when we're looking at psychiatric advance directives, these are recovery tools. They are complements to crisis plans, but not necessarily a crisis plan or a wellness plan. And a big difference in that is when we're looking at the audience. So with wellness plans and other forms of crisis planning, the audience can incorporate a wide variety of people, but when we're looking at PADs, these are documents for medical professionals. And we want to think about, in a crisis situation, these are clear, concise, and they're quick, easily absorbable, versus other forms of wellness planning where you can get a lot more in depth with your supporters. PADs are also legal documents about treatment, so they hold a different level of weight. And with that, they are rights protection documents. PADs are also a way for coordination of care. And I want to come from the perspective of, I am the expert on myself. I know myself, my internal world, my thoughts, my feelings, my beliefs. I know these better than anybody. So with the PAD, it's allowing each and every folks to take the opportunity to have their voices heard as the experts on themselves. They are also opportunities for feedback, which can be a way for us to track what's working, what's not working, and what's missing. And this can incorporate caregivers, supports, and loved ones, but this can also be a very good way for systems to see these trends. So if something is coming up repeatedly in PADs, and a lot of folks are saying, hey, I do not want this treatment, it's a valuable opportunity for that feedback and to take that assessment of, maybe this isn't something that's working, and maybe this needs to be less of a part of the treatment in these settings. Or on the flip side, if there's a form of treatment, or if there is a setting that people are frequently requesting, that's an opportunity for these providers to figure out ways to incorporate more of what is working. These are tools for holistic advocacy. So psychiatric advance directives are bringing a lot of different dimensions to really capture the whole person who is writing this document for themselves. And in doing that, and in being able to capture their voice and who they really are, that allows supporters, providers, caregivers, loved ones, all of these different folks to come in and to get on the same team. And when we're looking at PADs, to kind of sum this up, we're looking at a way to really have a voice for self-directed care. And what that means to me is taking the driver's seat in my own treatment and my recovery. Through having a voice and having a say in how I want to live my life and how I want to define my own recovery, for me, that's greatly improved the quality of care that I've received, and it's been a critical part in my wellness. When we're looking at improving the quality of care, we're looking at improving the access to care. So with the systems with behavioral health, unfortunately, they can be very overburdened and there's not enough resources for everyone. When we're improving the quality of care, like we had touched on a little bit earlier, that is going to help improve access of care with less hospitalizations and shorter stays to help more folks get the resources that they need. And Matthew and Amy, would either of you like to add on anything to this?
I got nothing. So unless you do, Matthew, I'm just going to take over on these next slides here.
Go for it.
And I guess as we do that, I just want to refer people back to a link that Ari shared in the chat on the National Resource Center on Psychiatric Advance Directives. And I say this now because one thing that we've really learned nationally in doing this work is that the language and the terminology of these things can be different in other states and other places. So here, we're going to talk about it as a Psychiatric Advance Directive. Some states call it mental health advance directives, mental health declarations, all these different things. On this slide that you see in front of you right now, it's about the different types of Psychiatric Advance Directives that there are. Declaration is one, but you might also hear this as instructional. Then there's power of attorney driven, but you might also hear this as agent driven or supporter driven. So I say all this and just recognizing that this terminology may change from place to place. And sometimes it's a matter of preference. Pennsylvania, for example, they use mental health advance directives, but I still know many people that still call it psychiatric advance directives there. So just wanted to give that disclosure. And as I go through what these three different types are, I also really encourage you to think about, if you were doing this for yourself, what would you want? What do you think would be a good fit for you? So a declaration, or as I said, instructional could be another word used here. This is really where it refers to a person's treatment wishes. What do you want in the way of treatment or services, and also what you don't want? But this is where it's like spelled out on paper, written down. Some places accept like a voice recording of what you want. Not all places. I think that's kind of a limited, but that does exist. But basically where you're giving instruction, communication in some way on what your wishes are. Then there's power of attorney or agent driven, which is where you give another individual the power to make decisions for you when you are deemed incapable of making decisions for yourself. So this is where you get to decide who that power of attorney or agent is for you, and what it is that you want them to advocate on your behalf about. Do you want them to go out and just make decisions for you, or do you want to kind of entrust them to know you well enough to make the decisions that you'd want for you? All important things to think about. And then some states have a combined declaration and power of attorney, where you can have both your written wishes or verbalized wishes out there and have a designated power of attorney. I will say that in my own journey with psychiatric advance directives, this has changed a bit, where I really wanted a combined document where I have both my written wishes, but I can kind of fall back on an agent or a supporter if I need to. But right now I have just the declaration. I still have not found like the entrusted supporter enough that I trust enough to really put in that position of power of attorney for me. So right now during this time, I've settled on having a declaration of psychiatric advance directive, and with that goal of eventually finding the supporter that I really can trust for that power of attorney place. Anything else, Matthew or Kaylee, to add to this before we get into the next piece?
No, I think it's just really important to recognize that you know, that is a foundational beginning point of you know, of the decision making, you know, once you really want to start doing this. I don't think you really want to move forward both personally or supporting someone else. And this part here, as you said, Amy, it brings up a more important topic in our life. I know, again, for my partner and I, when we had to think more broadly about this, because we had to think about our kids and who would take care of them, you know, it made us realize, like, who are the supporters in our lives that we would feel trusted with to do this, or even talk about it. And as well as, I have like a best friend who is in a situation where they're going through a divorce process, and we've been friends for a really long time, and some health issues came up. And I'm pretty much the person that, if anyone, is going to be there. And it was an easy conversation to say, hey, let's go out and hang out for a little bit and have a little serious conversation about, like, if we had to speak up for each other, what would we want, right? And that wasn't even about like writing the document. It was just about, if I get called upon because I'm the only person, what kind of decision you want me to make here, and so it really brings up a big thing about support and relationships in our lives, just to start here, and if we don't have that, doesn't mean we can't proceed. Like you said, Amy, we can start to just write down what we want, and if somebody cares enough to pick that up, best case scenario, it's legally binding. But worst case scenario, somebody cares to actually say, what would this person want? I was in a situation once where a sister of a person who was in a program of mine went on vacation, and that was the time in which the question about do not resuscitate happened. And I had formed such a good relationship with this person as their provider. We became quite close, and I became a trusted person. And the question came to me, and I thought, gosh, and this is for all the providers out there to consider, it's better to have these conversations, because in absence of having this document or having the conversation, you just might be the one that somebody's going to say, well, what do you think they would want? Well, I never had that conversation. I don't know. So this does take us into the next slide, which is start from the place of, this is about increasing choice and voice, being heard. If there's one thing that impacts all of our mental health, it's when we feel like we don't have choices and options in our lives, and we feel stuck. And sometimes that being stuck can be like, I feel stuck living a life where I'm going to feel like this every day. Now, I know that now that's not true, but I know what it was like to be in a place with my mental health feeling like, I don't know, I might just have to end it, because I can't live my whole life feeling this way. Now, the fallacy there was that things weren't going to change, right? And that's why we always need hope. But part of that was just knowing that there were choices in my life, and knowing that I had a voice. And so start from the place that developing a Psychiatric Advance Directive and supporting somebody with a Psychiatric Advance Directive is starting with, you have a choice and you have a voice, right? It may be a long way before we can put together this legal document, but that's where we have to start. And it increases safety for all of us. The more information we know about what it is that people would want and what works for them, it increases our cultural competency. So if we're providing it to somebody who's from a different culture or ours, there are little things that we could be making it worse because we don't understand the cultural background the person's coming from. And no one, I think we all have experienced this. I have multiple times. But if I'm not coordinating my healthcare, nobody else is. The insurance company can't quite do it. The doctor's office can't do it. There's all these new portals and platforms for my healthcare. Like, I have to be the one that tells my primary care with the specialist, and I have to constantly repeat it. So I think when I could write these things down, I could save myself some time, let alone if I'm not able to verbalize my wishes. I know how hard it can be just to coordinate my own healthcare, let alone if people who had to step in as my supporters, right? So again, it can also reduce hospitalizations, particularly rehospitalizations. It can be useful to criminal justice interactions. It can reduce homelessness as well, because a lot of times people end up in that situation because a crisis came and they fell right through because there were no supporters, or supporters that they felt they could trust, or supporters that they felt knew what they wanted. So particularly for some youth, they run away. They run away because they don't feel heard and accepted. So start from a place that this is about beginning to hear and listen to what is working, or what a person may know about what could work, right? Jumping right into like, what kind of medications you want or not want, what hospital you want to go to, especially starting off the conversation about hospital. Some people may think, wait, are you planning to put me in the hospital, right? That's why that's not going to be a good starting point. So what I'd like to do actually is provide some choice and voice from some partners of ours at Painted Brain, and just take a few minutes to hear from them. The next slide has a little video clip that they provided for us. So we just got to get to that. There we go.
Choice is important to me because so often people make decisions for me. Choice allows me to choose how I want to be helped, how I want to be served. Choice allows me to be free to make my own decisions. Choice allows me to voice what I want, what I need. Choice allows me to be free.
I am my choices, and choice is who we are. Everyone is a sum total of their choices. Choice makes us. When you deny me my choice, you deny me myself. Choice is important to me because I want to be the author of my own script, and especially when it's something as important as my own health. Too often, people say that those with disabilities should not be allowed to make their own choices.
I think the importance of choice and psychiatric advance directives is something that I think a lot of people overlook because they think like, of course, I have the power to choose. I can choose whatever I want. But sometime when your choices are questioned and someone says, you know what, this person doesn't make as good of choices as me, so this person shouldn't make any choices. This is often what happens to people in the psychiatric setting. Because they can't make some choices, they're deemed to be incapable of making all choices. And that's something that we really don't believe in.
Supported decision making is important to me because it's something that I do every day, all the time. Whether it's going out and asking a friend, hey, how do I change a tire? Going out and asking for advice on what you should do next in applying for a job process. Supported decision making is something that we do all the time without even realizing it. Too often, people with disabilities are told that they don't know or understand enough about themselves to make decisions for themselves. And this is used as an excuse to give them treatments that they don't agree with or to prescribe them medicines that they don't want to take. Supported decision making is something that should be available to everyone regardless of disability because it gives them agency and the ability to feel like they are in control of their decisions and what they decide to do in their lives.
Thanks. So we can definitely provide that link to folks if they want to hear more of that video, but thanks for that opportunity. We're going to move on to the next section here.
All right, so we've talked a little bit about psychiatric advance directives for ourselves, kind of, how family members, loved ones, supporters can be involved in that. We shared a little bit about how this also serves as quality improvement and serves our systems in other ways too. And this slide really continues into systems transformation. And how this continues to support our systems to be more recovery focused, more person-centered, and more of a client-driven system, which personally, I believe in all of those things. I hope our system continues transforming into those things. A psychiatric advance directive, once again, is recovery focused. It's cost effective. It actually reduces hospitalizations. It's a method of coordinating care. It's increases safety. It's culturally responsive, person-centered, increases choice and voice and self-direction and overall quality improvement. And we're going to get into this a little bit when we talk about an ASAR model later in the webinar. But just to kind of plant this seed on if you're involved in systems or a provider of some sorts, are you in the process of asking people, do they have a psychiatric advance directive? That's one way that it can help improve in a individual provider level this increased care and better care that people have. And are people there offered the opportunity to develop a PAD? So just to be thinking about this in either the systems that you and your family get services from or that you're providing, these can be really important questions.
So I'd like to get into talking a little bit about the elements of PADS. And a big part of this is when we're talking about the reasons behind our preferences, we really want to paint a picture of what these preferences are, but also why. And part of that can help incorporate a lot of parts of culture, background, medical history. So say, for example, and I want to preface as well, different states have different requirements for forms. In the state of Maryland, the form for a written or an instructional element of the Psychiatric Advance Directive is not, there's not a standardized form. So you would have the ability to add a little bit more depending on certain states. But saying something like, I don't want to take antidepressants doesn't paint as much of a picture as I don't want to take this specific antidepressant because in the past, this is what has happened. And that reason is really about capturing the whole person and helping everyone get on the same page. So some of this information that can be provided and captured in PADS, we can look at things like current prescription medications that we're taking, even things like supplements that are being taken, medications that have worked in the past, as well as medications that have not worked in the past. I know for me personally, there is a type of medication that I've had a very extreme reaction to. And if I am in a state where I can't verbalize or articulate what that medication is or what it has done in the past, there's a chance that it could be given to me again if I am in a crisis setting. Another part that can be provided is preferences or concerns about treatment options. So some folks may have preferences regarding electric convulsive therapy or experimental studies, even different treatment facilities. Maybe someone's had a very positive experience in one type of hospital setting, and they would like to make that clear. That is something that could be added into a psychiatric advance directive. Other information that can be provided is preferences with emergency treatments. And when I'm hearing this, I'm thinking about certain treatments that may be used in safety instances. So this can incorporate things like restraints or seclusions. And a way to attach a reason to that would be, I do not want to be secluded because I have a past history of X, Y, and Z trauma. It really can help paint a full picture. Other things, ways to reduce or avoid those emergency treatments. For me personally, if I'm becoming escalated, something that really helps me is having someone sit down and talk, not even talk, but to listen to me. So something that's important for me to voice is peer support is helpful for me. Something that makes things worse is being ignored or brushed aside. And other things as well that can be included is release of informations, emergency contacts, and different ways to incorporate our supports. And when we're looking at relationships between crisis plan and psychiatric advance directives, like we had kind of spoken to earlier, these are meant to be complements, but not necessarily crisis planning. And again, that kind of gets on the audience and the legal rights protection documents. Personally, I use both, and having both has been very helpful for me.
So I think I was going to speak on this, but for the sake of time, we're going to move on to the next one. Essentially, what we're talking about is, crisis planning is a process that can begin before you do the psychiatric advance directive, and is a part of creating that whole continuum as we kind of talked about. So I think we essentially hear what you get overall from the theme of this presentation is that there are a lot of these things that we can kind of do before, after, and during the crisis plan, developing a psychiatric advance directive. So
Yeah, and as Matthew stated that, I will also just articulate that like crisis really happens on a continuum of you know, a lot of different people potentially involved, sometimes hospitalization, sometimes community support, and a lot of what we're talking about in crisis planning can be applied to varying parts of that continuum. And then, as like Kaylee mentioned, the Psychiatric Advance Directive piece is really meant for the medical professionals within that hospital setting. But it is really important to think about things like these critical extras of, is there information for law enforcement or first responders or crisis personnel, such as like mobile crisis teams that may be coming out? One thing I think, you know, is really important to recognize is that police involvement is not always helpful, and actually sometimes is very unsafe for folks, or people feel that it's very unsafe. So being able to articulate what else can happen if somebody needs to be called in for support. Maybe I don't want law enforcement there, but I'm okay with a mobile crisis team being a support. And how can I articulate that to my supporters in this crisis planning in a way that would be helpful? I think some other things that would be like helpful critical extras is people knowing, where can your psychiatric advance directive be found, or where can your crisis plan be found? And things like, you know, what I would have here in information and like providing crisis teams or law enforcement is like this idea of like, always provide me with choices and options. Don't be demanding of like what I'm going to do and how I'm going to do it. Let me make those choices and options about that. That kind of ties into the helpful critical extras, how we can provide information about the things that may help de-escalate us during a crisis, or the things that may make things worse. Some examples of this for me is things that would help de-escalate: definitely going for a walk. I am a pacer. I like to walk around. It helps me reflect. It helps me process. If a supporter's with me, I can kind of vent out all the things that are circling on in my mind. Walking it out is really helpful. Also things like, just let me lay in the grass. So all I want to do is just lay down in the grass and do some grounding and connect to the earth. Those would be things that I would find very helpful. But there's things that may make it worse, like I said, demands from other people. You know, you need to go do this because you did that. That kind of demanding way doesn't sit well with me. I just want to push back and rebel and go a different direction than that. Another thing that you know, I recognize not everybody is this way, but I am. I'm not a hugger. So a lot of people will think that like, oh my goodness, somebody's in crisis, they're very emotional, they just need a lot of hugs. If you come up and you try to hug me when I'm in crisis, you're probably gonna not be very happy you did that. So I try to articulate to people that like, that's not something that I find helpful, and can really make things worse for me and for you. So those were a couple things I wanted to say about that. Kaylee or Matthew, anything to add to that quickly?
Yes. So in regards to mobile crisis teams and how they can play a part, I come from a background of working on a mobile crisis team, and unfortunately, there were situations where we would accompany the person that we were serving to the emergency room for further evaluation and treatment. One way that mobile crisis teams can help with this advocacy is in these warm handoff situations, letting the staff and the behavioral health teams there know that this person has a psychiatric advance directive. In the state of Maryland, we have a database that has been vetted and is compliant with the regulations to store these psychiatric advance directives, which is called mydirectives.com. And I believe I saw Michael on here from that organization. But that could be a role mobile crisis teams could play, is that advocacy of letting these emergency workers know that this is something the person has.
Yeah, I would just add that, you know, as time goes on, I learn more and more about other health factors that really should be ruled out before mental health is incorporated. So, you know, for example, you know, it's really helpful to know, particularly if a group of strangers that are first responders that are getting involved, that this person maybe has diabetes, and because there are dimensions of that could show up looking like mental health, but are actually related to insulin and other things such as thyroid and etc. And just as time goes on, I meet more and more people, and my own life is included, that there are other factors that play a role, and they can look like mental health things. And you know, I, for example, was in a situation recently. We went to the ER, and you know, thankfully I have a mental health background, so I intervened before they just provided my partner with antidepressants and anti-anxiety medications, sent him out the door, because they were misreading what was actually happening at the time. We found out later was a stroke. And very quick to just see the fidgeting and the nervousness and the anxiousness, which was really just related to the whole unknown of what was going on. And so, you know, this is a factor that I look for when I'm supporting my partner in these situations, because I'm just seeing more and more there's a very quick response to look at those behaviors and prescribe or make that assumption. So if you know that there are these other factors that are overlapping with your mental health, you know, it can be really helpful to make sure that you have supporters, that it's written down and it's documented. Again, it can lead to a case where people are liable for making the wrong call when the right information was provided to them. But if it's not provided to them, it's kind of hard to hold them accountable for making that wrong call.
So moving into this next slide, I want to bring us back to something Kaylee said earlier on another slide on, you know, our goal is generally not being hospitalized. I'm sure we can all think to times either we ourselves were in a hospital for medical conditions or psychiatric conditions. And our lives are in the community. Our lives are at home. So this is a slide that really helps us think about, well, how do we still take care of our lives that are still moving with us or without us if we are at a place of hospitalization or away from our homes and our normal lives. So it's also important to think about preparing in advance for our household needs. How is our rent going to get paid? Our bills, our pets getting taken care of? Matthew mentioned our children. I have 2 kids. I know I need to make sure that there's a plan for somebody caring for them if I cannot. If we have plants, who's going to check our mail? One that's not on here that I always think is really important to say is, if I have to like go to a hospital for a few weeks, please somebody check on the food in my fridge, so I'm not coming back to all this like moldy food that I need to throw out afterwards. Such a simple thing that we can ask and prepare in advance by just simply asking that thing of our supporters. Also, things like employment, securing our jobs under FMLA, or thinking about if I'm not able to show up to work, is there somebody that's going to call my boss or my employer and let them know what's going on? And what am I comfortable with them sharing with my employer? Having those conversations. Likewise, with education, this is especially important for youth, young adults, people that are maintaining financial aid and enrollment status, making sure that those things are being responded to, so we don't lose a lot of the work and the hefty lifting that we've had to do to maintain and get the financial aid or enrollment to begin with. Similar with public benefits and application processes. Sometimes people can be on housing lists for years. I'd hate to get that call that housing becomes available when I'm hospitalized and lose it because of a hospitalization. So is there somebody that can support that if I'm not able to? And then probation or involvement with the justice system. How do we continue to support our goal of like ending our cycle of incarceration or fines? Is there somebody that needs to maybe contact our probation officer so we're not, you know, getting in trouble for missed appointments with them? Or things like that. So just thinking about all these things going on in our lives, if we're not able to take care of them, how can we direct our supporters to help take care of them for us?
Thanks, Amy. So we're going to talk a little bit about, you know, how do we kind of, sounds like from the chat, a lot of people are like, this is a really good idea. We need to do more of this. And it really is upon the peer support and family support movement that it's really going to be critical for the outreach and the engagement of this. There is substantial research that whenever it comes to public health initiatives, health education initiatives, I mean, this stems from everything from how we actually reduced HIV infection to the major strides we've made in, juvenile justice issues. The research is pretty strong that when people who are from those communities with the lived experience are the ones doing the outreach and engagement, that they're having the greatest impact. One of the research studies basically showed us that people who were affected by and living with HIV and in those communities had a significantly larger impact in reducing the spread of HIV than any kind of anecdotal or medical intervention. That public health education is critical. I think we all know that although there are great strides in medical treatment and there are great things that we can help us medically out there, that 98% of what impacts our health is everything else outside of that connection to that medical situation, right? And it requires getting better healthcare and getting well, and really knowing what it is that supports us, and knowing what the difference between a lifestyle issue and a medical issue that we need, and providing our medical providers with some of those details about things, is going to come best when we get to share and learn from each other. And that goes hugely too for family members dealing with a loved one who is having, these health situations. The criticalness of them supporting each other through that and sharing what they're learning, not just about the treatment options that are out there, but the 98% of the time at home, what to do, right? As well. Peer and family peer supports bring a level of trust, communication, and credibility that nobody else is going to bring. One of the things that we all have to do, though, to do that well, is we have to really think about what are our answers to all these questions. What would we want into all these questions? Because the most powerful way that we engage is giving illustrations to our own personal stories. I see that many people here are saying they really liked some of the examples that Kaylee and Amy were giving, right? And that's the kind of engagement you get when people know their own stuff and are willing to share it. A peer and family supporter can create a greater connection. Peer supporters and family supporters come from authentically from the community is also going to bring a cultural competency to that conversation as well, just by the very nature of it. So I want to talk about on the next slide this kind of model that was something I began to implement at a provider agency when I worked there. And I had a really amazing executive director who said, Matthew, this is a really great idea. This is before there was even a law in our state. There wasn't even a law. And they were like, I really would like all of our folks at our agency to help people develop advance directives, right? And so part of that was figuring out, and when I did that and I began to provide trainings to my colleagues throughout that agency, that's actually when I realized some of the biggest stigmas towards the people we were serving were the people who were serving them, right? And at that time, people didn't know about my own lived experience, and they would say things like, these folks can't make these decisions. And, and I started recognizing, what are we doing here if we don't believe in the capacity for people to learn and grow about themselves? Of course, secretly, I'm like, my own experience and so many of my friends, it's like, no, we know it may take us a while, or we may not know right away, but we know and learn and grow. And quite honestly, all this stuff we're talking about came from people with lived experience. They developed these things. They developed these questions, right? So one of the things that we did, and this is something I think we all need to engage in, is we need to all just beginning to start asking each other, right? Do you have one? Would you want one? Would you, like we started this off, would you want someone who is a trusted person to be involved in decisions when you can't? And almost all of us said yes, right? And when people say yes, we offer support. How can we support you with that? Where do we want to begin, right? If people say no, I don't want to, then we had a protocol of, okay, 60 days later, ask again, right? Because maybe it wasn't the right time. Then we support people with that. And then comes the moment when that information becomes valuable. Then we have to advocate. And then after the situation is a time to revise, because then we learn, okay, you know what, we were missing something from that plan, right? And so this is a very simple model called ASAR: ask, support, advocate, revise. If we can kind of go to the next slide, I'll just kind of highlight, and this is going to be provided to everybody. So, you know, I'm just going to share, you know, in short, you know, this is what an organization or a community can do, is to put that in within 30 days. Do you have, or you ever heard of one, right? Offer options for peer learning through it, one-on-one learning through it. Make sure there's advocating requires that we have copies and the right people have them, and the right people are coordinated. So when something happens, somebody calls them so they can bring that document. And like I said, we want to think about how we can revise that. It's really promoting this idea that everyone's voice matters and that we can learn and grow. And we know best because we live in our bodies, right? And if we're not providing that information, how are people going to know? So the next slide really touches on the fact that what we've learned in the evidence-based approach to this practice is that there are certain core values that we that are critical to engaging with this. And again, this is going to be provided to you. So I think for the sake of time, I'm going to say, please take these values very seriously. If you're going to engage in a conversation with somebody to support them to develop this, follow these values. It's evidence-based.
Just wanted to let people know that these slides are available, so you'll be able to read all of that. You'll be able to get access to these resources, as well as the contact information. You guys have been awesome. There's been so much information. We really appreciate getting all of it. I do want to apologize that we're not going to have time for Q&A, but I do want you to please go and take our survey. I'd like to thank our funders, the Takeda Lundbeck Alliance, the Johnson & Johnson Innovative Medicine, the Massachusetts Department of Public Health Suicide Prevention Program, as well as our corporate members, Sage Therapeutics and Biogen, Takeda, Johnson & Johnson Innovative Medicine, and Alkermes. Our survey is at surveymonkey.com/r/ADMAR24 or ADMAR24. Remember, please, to join us on Thursday, April 4th at 7 o'clock on Facebook or YouTube for more discussion about this. And just wanted to say we're also grateful to people like you who give us your input and who support us financially when you can. Every contribution is meaningful to us and tells us that we're doing something that you value. So if you are inclined and able, please make your gift at familyaware.org/donate. Thank you all very much for coming. We really appreciate your time. Thank you, Amy, Matthew, and Kaylee. Thank you, Ari, for all your work on the back end, and have a really pleasant evening. Good night.